And Alexander's joining us, midnight in Switzerland? Yeah, midnight. So we've got a great speaker lineup for you again. And I know that I've hosted these two outstanding surgeons and researchers before. We've got Dr. Rafe Mobbs and Dr. Prashanth Rao, both from Sydney, UNSW, or University of New South Wales, multiple publications. I'm sure that you've read their work at some point in time. And we've also got our great panelists and virtual spine founders here, Ali, Wendy, we've got Nadir, Mike Algano, John Rasuli, Alexander. And so what we're running is a chat box. If you've got any questions, fire away. The panel will also chime in at various times. I think Prashanth was going to go first. And today we're talking about outcomes in spine surgery. And even though this is pretty boring, it's a really important topic. And I remember Rafe saying to me a few years ago, we get these patients that come back to us and they say, I'm still not right after spine surgery. And you actually drill down into what they're doing, and they're walking 5 times longer. Their pain's dramatically reduced. It's just they're not perfect, right? So they're not 100% happy. So some of it's about how we deal with that sort of patient, and some of it's about how we collect data and actually present that data in a meaningful way, and how we protect ourselves from the long arm of insurers and government trying to interfere with what we do. So I will introduce Prashanth to give his talk. He is a neurosurgeon. The only flaw in his career was he was previously my fellow, so he had 6 months of bad influence. But he's moved on from that, and he's a very successful surgeon in Sydney in private practice there, but also still producing a huge amount of research. And I'll let him talk. Thank you.
Thanks, Mike. I'll start sharing this screen. So it's an interesting topic. So we're going to distribute into 2 parts of the story, and I'm going to start with the outcomes in spine surgery and mostly concentrating on the subjective outcomes, and Rafe is going to join with the next topic. So the first important thing is what to measure. We all measure different things. There is ODI, the SF, sisterhood of multiple things, 12, 36, I don't know what's coming next, the VAS, RMDQ, SRS30. Not all of them are validated. Some of them are very good, validated, and are very important to measure. In my practice, I measure ODI, VAS, the EQ5D, RMDQ, and for neck I do NDI. So it can work. So this is in our study on a whole bunch of spinal surgeries, where we looked at pre and post-operative outcomes in terms of gait, but at the same time we measure all this, and you can see that pre and post there is definite improvement, and that is very important, that these outcomes do tell us what some of the things that we'd like to know. So that's very important. So it's very important to measure these outcomes because they do tell a story. Now, why is it important? Like, you need to measure it, correct, but why do we need to measure it? So there are 2 parts to this. The one is the surgeon's point of view. Like, we'd like to know how our patients are doing. We'd like to know if what we're doing is doing the job it needs to do. Some of the treatment we'd like to optimize, we would like to change because that'll help us make their outcomes better. There are new techniques being introduced regularly, and currently we've got endoscopic and then the robotic. Are these as good as the old ones, or can we do better? The final thing is audit. Are you good enough with your peers, or what is being published or said to? Does it work for you? Is it equal to what you're doing, or is it something different? I think it's very important. The next part becomes the more contentious issue, and I think this is where we're not going to be able to hide, and it's very important that the healthcare providers, the government, the insurers, the Medicare, etc., are going to be interested in finding out, well, what they are spending, is it well spent? Can we actually minimize this wasteful expenditure? Is any of this treatment obsolete? Should we just take them out? And I think this is a very important topic, and I think we need to invest ourselves into this, because that's a very important point, because they're going to one day come and say, sorry, you can't do an operation because of X, Y, and Z. So I think this is a very important part for us as well. I'm going to briefly explain this. So from the surgeon's point of view, so this is an example. So this is a 30-year-old occupational therapist who came with severe neck pain, radicular pain, and right-sided weakness. As you can see, there's a kyphotic deformity, multi-level disc prolapses, and I did a 2-level fusion and a disc replacement at the top. And as you can see, the outcome scores are important. At surgery, pre-surgery, 3 months, 6 months, there's a clear-cut improvement, overall health, NDI, EQ5D, they're all improving. And you know that you've made a difference. And, you know, there's again an important thing about minimally clinical important difference, which, you know, you all need to maintain so that we know that what we're doing works. The treatment optimization, again, this is important. So I used to do, you know, there's a lady, I did a multi-level fusion for severe back and radicular pain, did well, and as you can see, I've extended up to the pelvis, and started noticing that these multi-level fusions with just pelvic fixation with screws, they do tend to cause problems, and this lady had SIJ issues. You can see a bit of haloing around the screw, and then I did SIJ fusion added to this. And routinely, what has changed now is multi-level fusions going to pelvis. I routinely now do bedrock to help improve these outcomes. And I think that's where it starts to know that you're looking at your you know, outcomes. You're saying, okay, this doesn't work, or this doesn't work, so I'm going to change my practice. And I think looking at future is also very important to see if this works.
Can I, sorry to interrupt, just real quick. Can I ask you a technical question on that last case?
Please.
Something that got my attention, and I have been, the previous slide.
Yep, go back.
So it's got my attention, and you know, I like many of us who do social media, we try not to get too controversial, maybe just a little bit. But
yep.
I have a collection of a lot of SI joint implants and fusions and things like that, like a whole barrage of them. And I've always said, you know, boy, you know, one day when, you know, if I really want to get a controversy going, I'm going to put those x-rays and say, and the caption is going to be, there's an all-out assault on the SI joint, you know, and I haven't done that yet. I don't think I will, but I do have a question for you that's actually technically has caused me a lot of issues, and I don't know what the answer to it is. When you do a long construct into the pelvis, whether it's traditional iliac bolts or S2LR iliacs, whichever your method is, at what point, when you get this CAT scan and patients have pain and you see loosening, at what point do you consider, oh, the best thing to do is to snip those two bolts and take them out, versus augment the construct with fusion, bedrock, et cetera? In other words, how do you differentiate what the patient needs? Do they need the hardware just out at the bottom, or do they need more fusion kind of technology? So I'd love to hear your opinion, and perhaps others, you know, Mike, I know you have experience in this, but any other of our colleagues, what their experience in this field is.
Very good question, Ali. I've actually not thought about taking the bottom out, because I still believe that I think the bottom has got much more important work to do. And particularly if you're looking at the CT on the left side, there is so much of vacuum phenomenon into the SI joints. And, you know, I do fuse SI joints not routinely, after all, exhausting all of the ways of treating it. And I do believe just the more the fusion, the better at this level, particularly if you have already got multi-level fusion above it. So I'd like to hear from Mike. I don't know. I've not actually taken out the screws.
Yeah, I think both options exist, and certainly in the pediatric population, we've ended up removing them in the past. The long neuromuscular scoliosis cases can get loose there with time, and often they just, in the past, used to just take them out. I think the bedrock technique is a really good technique. I haven't had one case of SIJ arthropathy or major loosening since I've been doing it the last 3 years, and I had 1 or 2 per year before that. So nothing disastrous in a practice where I do a lot of pelvic fixation, but it was just enough that with the way I navigate now, it's an additional 10 minutes in the operation. So to me, it's worth it. But I understand what Ali's saying as well. This is a controversial area. In Australia, we don't have quite the same uptake of SIJ fusion amongst, let's say, the non-surgical group, interventionalists. We don't have that. So we've got kind of surgeons making decisions on SIJ fixation here. And it's not being done in a outpatient day surgery center by someone not really trained in biomechanics. Let's put it that way.
Got it. Got it. Thank you, gentlemen. Thank you for that.
Very good. So so that just means we're going to do an SIJ talk one day. The next part is audit, and I think this is interesting. This is important. That is, are you equal to your peers? And I think it's where we need to look at what we are getting in terms of our own results are equal to what is accepted to be normal, not just locally, you know, at the national level, international level. I think it's very important. And I'm just going to point this out. This study has always created more controversies and more interest, and this is Europe versus America, and we in Australia kind of look at both of you and find, you know, interesting work for us here, because we kind of half and half in our work. So these are the 2 articles I'm sure you guys have all come across for lumbar stenosis with spondylolisthesis. 2 randomized controlled trials came up in 2016. And one was from Swedish spine study group, and the other one was from US. And the interesting thing for me, apart from the fact that both of them found different answers, and then there were different ways of they measured things, and so it's made it still more controversial. But interesting thing I looked at was the complication rate from the Swedish spine study group, that in decompression, they had about 11% dural tests, 4% infections, 3% of MI, thromboembolic stroke, etc. And in infusion, much more higher. And, you know, 10% infection rate in a fusion, I think is high. 4% is still high for me. Dural test is also high. So looking at that, is this equal to what I do or what I believe is right? So that's where it comes to me. Again, the surgical complications in the others group was about 6% of major complications in decompression alone group. So where is so this is our study that we published, and our complication rate in this was about 4%. So I think this is very important to measure and say, well, if this study was done by me, would this be my results? Then I think this is when the next controversy comes, is insurer. What's the insurer going to do? And this is quite an important topic. So we do get independent medical reviews, and quite a few of them. One will say fusion doesn't do well at all, but it's not true. Like we published on this. This is a study on ALIF, prospective study, and we know that in well-selected patients, pre and post surgery, there's definitely an improvement. This is for the VAS, this is for ODI. So definitely it works in well-selected patients, but I think it's very important that we maintain the database so we know when somebody asks you a question, why does it, what you do, that it works. The next question was workers' compensation doesn't do well. We know it is a difficult scenario here, but again, we published And we noticed that, minimal clinical difference is similar, whether it's workers' compensation or non-workers' compensation. So they do well. I think is the selection bias is very important. The next part is, well, I don't know how it's happening in US or elsewhere in the world, but the insurer or the people who have interest in funding these things will have an interest in finding out if some things work or not. So I'm just going to point out to vertebroplasty. I don't know, I think it's in US, it's still prevalent, but in 2009, vertebroplasty was removed from Australian MBS items. And this was based on a very good Cochrane review, found high quality evidence that vertebroplasty was no better than placebo. And this was a pooled data of RCTs, including the one from Australia. But there were some limitations. There were both a mixture of acute and chronic patients, and the VAS median was about 5. So there were some limitations in the study, but this was taken out. And I actually don't remember doing vertebroplasty on their own since then. But I've been told it's come back in 2020. Again, another RCT showing that it does work in some well-selected patients, less than 3-week-old in severe pain, etc. So it's very important that this is going to come to us. We're going to have to look for and make sure we maintain very strong database to look for, well, is this going to be the future? If we need to have proof that what we do works. So for that, we are doing a study. We are part of a study in Australia for the first randomized placebo-controlled decompression surgery in lumbar stenosis. So surgery was a sham surgery. So still going on. We'll find out soon. Now, the next part is subjective scores all correct? Well, it's quite easy to administer, although some people have said it's quite difficult, but I think it's quite easy. Most of them do fill up. It becomes much more difficult for older people to fill up, and people do get bored if they have actually had good results. Some are validated, not all are validated, but I think it's very important to measure. Now, there are quite a few cons. There is inherent bias, particularly if you have one person one day doing really well, but the other day, not so much. And if you have collected the data on the day they're really bad, then you get wrong answers or maybe right answers. There are quite a few articles which are published that each different score measures different variables. So it's also very important. For example, you looked at the lumbar spinal stenosis, 2 randomized controlled trials. One looked at SF36, the physical part of it, and the ODI, and they got 2 different results as having primary outcomes. So I think they're measuring different things. And the very important thing, they don't correlate with each other. So one may be positive, one may be negative. So it's very important to note that each one of those scores are measuring different things. Maybe you need a panel of these scores. It is contentious in compensation patients. It's also important to note that the correlation between pain scores and disability and ambulatory function, we in fact also looked at our own study that with axillary and the disability scores, there was no correlation. People were saying, I'm still not great, we're doing much better in terms of physical activity. So it's very important to note that there is a caveat there as well. I'm going to stop this by giving an example of how things do change and why we need to think about it. So this is a 68-year-old, came with severe back pain, right-sided sciatica, weakness, and he underwent a 4-5 anterior psoas fusion with perc screws, did really great. In fact, I remember this guy saying that the nurses were so happy that this, he's such a great performer. He just did well, got up, walked out. Great results for about 5 weeks till he saw me, and this was the intraop X-ray, sorry. And he what's happened there? Sorry. So around 5 weeks, he came back, severe pain on the left side this time, really bad pain after physio intervention about 3 weeks. I generally routinely say not to do any intervention till about active physio till about 6 weeks. And he just came to me saying, pain is the same as before. It's a waste of surgery. It was on the right side, now it's on the left side. What's the difference? So he had all the scans, it's CT, MRI, no compression, screws, cages in right places. On examination, he had SRJ positive procative tests, and so had a SRJ injection, good short-term result, came back after a couple of weeks, had a radio frequency ablation, and then great, he says good as gold. So moral of this story, subject discourse, don't tell the whole story. This man had a great result, then some setback, again, good result. If we hadn't gone to SRJ injection radio frequency, this is a lost case, he would be very unhappy. So there is a continuum. Spine is not static, it changes. You do something intervention, there is more stress on the next level or the level above, and things changed as long as you're able to manage the symptoms with simple things, and I think things can get better. And the other important thing is the pain source could be difficult to identify, and I think similar pain can arise from different sources. I think that's about it. Questions?
Thanks, Prashanth. That was brilliant. Hey, I was going to ask you, sort of in relevance to the last case, and you know, we hear a lot of naysayers, at least in Australia, and you've probably got them all around the world as well. But we get people going on the media here saying spine surgery doesn't work, and we've got, you know, physios on social media saying spine surgery never works. And yeah, I think this is a sort of attitude that we have combat a little bit. When you look at the sport study, so the seminal sport trial and the long-term outcomes, some people will point to that, particularly in the laminectomy group, and say, long-term laminectomy didn't really work. And my take on that is when you drill down and look at all the outcome measures, many of the questions in those surveys that they use are affected by the aging process. And 7 to 10 years post-sport, many of those laminectomy patients who were in their 60s or 70s when they had the surgery are generally not as active as they would be. Hip and knee osteoarthritis takes over some patients, SIJ occasionally. What's your take on the diminishing results in long-term studies like sport?
I think it's a very important question you raised, Mike. I think the belief that spine is static or the body is static is such a wrong notion. There is a genetic determined degeneration that occurs. There is determination that things with aging, things go bad, and other things come back. And it's very important that you need to measure what you need to measure at those outcome years. Like, it's good to say 10 years they did great, but does it always work like that? No, it doesn't. Things keep changing. So I think long-term outcomes are good, but there is a caveat that you need to look at. I still think that it's a continuum, and we need to be looking at that way in terms of the outcomes. A spine is not static, or the body is not static.
I just saw on the chat, Prashanth and Matthew Birchuk, who's a great contributor to this forum, has said, from your case, the primary pathology was a right-sided facet cyst. If flex extension films are negative, why not just do a simple decompression? I think that's a great question, but it's also perhaps the topic of a whole potential meeting as to what to do about facet cysts, because I know there are a bunch of different opinions out there. Just really quickly, what's your rationale for fusing facet cysts, Prashanth? Is there
I routinely don't. I agree with Matthew. I would generally do only a simple decompression in here. And this guy did have a flexion extension films. Did it show dynamic instability? And his was not just a pure leg pain. He had chronic back pain with really bad facet arthritis at that level as well. And I offered him both of them, and he said, just fix me. I'm really sick and tired of this. Yeah. He's a typical Aussie bloke.
Yeah. And Wendy has mentioned whether we send them for CT guided fenestration in Australia. I have to say, other than seeing Wendy present on it, I haven't actually had too many cases that I have got the radiologist to try. I haven't seen it be too successful. Certainly, we'll do nerve root block and epidural injections, but haven't done the fenestration too often. Prashanth, have you got a radiologist that can do a CT guided fenestration of those and that actually works, or what's your experience with that?
Actually, same as you, Mike. I haven't had any CT guided fenestrations. Probably Ray would probably be able to answer this. We did write a paper about it, but
Yeah.
I mean, the great thing about CT fenestration, folks, is that it's part one of a two-part procedure. So part one is the fenestration, and then you get them back in a month or two when it's come back. The other, in terms of answering the facet cyst fuse or not to fuse, there are actually some reasonably good papers out there to say that if there's no spondy, then you probably shouldn't fuse. If there is a spondy, you probably should fuse, as the spondy is an immediate reflection of the fact of that facet joint has become it's become an unstable situation. So, yeah.
Yeah.
Facet cyst as another talk, I actually think that would be really important. In the literature, you'd be really surprised. There's actually stuff all on facet cysts in the literature. Yeah, that's actually a really common pathology that we see. So I think it totally warrants its own session.
I was just gonna.
Oh, sorry.
Sorry, Mike. If I can just chime in. I know we have to go to Dr. Mobs here, but really a couple of good points that are brought up here in the last couple of minutes. I think right now, I don't know what other practices are like, but if I have a patient with a large symptomatic synovial cyst who has not attempted some kind of either pain management strategy or fenestration, or some pain management docs or radiologists like to call it aspiration, but for us that's really, I think for a lot of us that's now standard in the absence of acute neurological deficits, which they rarely have. So I think not only for insurance purposes do we have to document that they are actually attempted, non-open surgical options, but I also think it's good medicine. I've been utilizing that more and more, and I have to be honest, I probably haven't seen a lot of patients come back. I don't know if they've had surgery somewhere else or hopefully they just got better. So I think that's becoming more and more standard for a lot of us here in the US. But the second comment regarding that last case, and I'd love to pick your brains, you, Dr. Rao and Mobs, over kind of on in your part of the world, what your thoughts on severe stenosis, severe lumbar stenosis, whether it's from synovial cyst or ligamentum flavum hypertrophy, patients that come in with back pain, not so much neuroclaudication, but severe back pain. They don't have a deformity, they don't have scoliosis or instability, but they have severe lumbar stenosis, right? We don't see it that much because usually they have neurogenic claudication, but once in a while, I'll give that patient the benefit of the doubt and do a decompression in the hopes that their back pain, that it helps their back pain. But I wanted to know your thoughts on that because Prashanth, I know you showed that one of your rationale for the fusion was, well, they also had back pain, not just leg pain. But I'm wondering whether or not some patients will get better with a decompression in terms of back, not just leg symptoms. I know there's a lot there, but I'd love to hear your opinion.
It's a very good question, Ali. And in fact, I tell the patients who have a combination of lumbar stenosis with radicular pain or neurogenic claudication that I wouldn't routinely fuse them. I actually give them the option of actually doing a simple decompression. And I feel that 30, maybe 40% of them actually get better with their back pain as well. And I tell them that if there is still ongoing back pain, then we will investigate this further. But I wouldn't like to do a fusion just for the sake of, because they also have back pain kind of a thing. So it is, I see that about 30-40% of them don't need anything to be done at all. And, I then do further things, bone scans, simple injections, ongoing physio, everything. And I think that's where, again, I if there is a stenosis that I'm actually operating, I do an unilateral approach for bilateral decompression to minimize, injury to the ligaments and muscles and prevent, even if they have a grade 1 spondy, I would do a simple decompression first and wouldn't fuse them unless they become they're very symptomatic.
Well, I actually agree. I think that in a lot of cases, the back pain gets better because their walking improves, that their sagittal balance improves, that they can stand upright, that they don't get additional load on their hips because they're walking in such a forward stooped angle. Well, I think that a lot of these patients with back pain, I mean, that's not our teaching, that's not the traditional teaching, but it's but I think that more often than not, that a lot of their back pain gets better.
Yeah, I suppose my only comment on this is I use epidurals a lot and still do some of my own, and I'm not afraid to do one just with local anesthetic only, long-acting local, and see what the response is. And I think sometimes some of these patients with stenosis, dominant back pain, very little true radiculopathy or claudican symptoms, if you do an epidural and they say everything got better, I think that may be an argument to decompress them alone. But I use response to blocks to guide my practice a lot, because spine's hard. We struggle to differentiate between facet arthropathy, neural compression and other things. I mean, yesterday I injected a guy myself. I did a S1 retrograde foraminal block for a young fellow who's in his late 30s. He's seen about 5 surgeons with leg pain. And he's got radicular leg pain down the back of his left leg that stops 2 centimeters below the knee. And everyone said, look, it's not S1, it's not S1. And he's got an old disc protrusion at 5.1 that's tiny, but you can see it just abutting the left S1 root. And no one would decompress that I know, usually. But I've had a similar case, did an S1 retrograde block, patient was perfect for 24, 48 hours. We explored the root and the disc was completely adherent to the root. So there'd been a previous injury, resorption of the disc fragment and a heap of scar tissue, which is hard to pick up on MR. And the patient hadn't had surgery before. And I think this is a similar case. So I think response to blocks, targeted blocks, to me is very, very helpful in my practice. And it helps you document the process and explain things to the patient as well. And it creates a good relationship, I think, a relationship of trust as well. So it's an important part for me, but I recognize not everyone wants to do things that way.
I think it's a good point, Mike. I think some people also say, I don't want to block. And I do say that it's very important that we want to make sure what we're going to do is going to help or not help.
All right, beautiful. So we're going to move on to Rafe's talk, half full or half empty. And yeah, let's hear this. I'm looking forward to it.
All right, folks, this is going to be a very, very different presentation. And I'm more going to sow the seed of some questions for your own practice rather than answering any questions. So hear me out for 15 minutes. So measuring what we do in spine, I've got to tell you, it's probably the most important thing that we do, because everyone not only wants, but they have the right to have access to that information. Insurance companies, governments. If we're trying out new techniques, technology, we need to demonstrate benefits to make sure that that our own personal outcomes are good, and the list goes on and on. So we really do need good answers. And let me paint you a picture. So my brother runs an insurance company in Australia, and for years, in fact, for decades, he's been telling me that in medicine, you guys keep crap data. In all the other aspects of where I run my insurance company, I've got fantastic data. In my shipping industry, I know what every ship is doing every millisecond of the day, where they are, what they're doing, what the metrics are. It's all about metrics capture. And travel industry, the shipping industry, whatever industry. However, we come to the medical industry, and specifically a lot of what we do in surgery, and we've got to accept that we've got crap data. We give governments, we give insurance companies, we give patients poor data points, and that's something that I want you to try and sort of like sink into your head while I'm giving this presentation. So, what tools have we been using for the last 50 years? Well, I've got to tell you, the tools have been pretty crap. they're pretty subjective, right? I mean, truck driver, professor, skinhead, fashion guru. It's involved ticking boxes, reams of this. We are trying to determine what is a primary outcome measure. And this is a trick. Prashanth brought this up. This is a very sneaky trick by the mob out there that want to try and demonstrate that surgery doesn't work, that you pick the right primary outcome measure to do your statistical trickery to show that there's bugger all effect. It's been done time and time again. You can quote me on that. Issues of timing, daily variance. We know that if you've had a cup of coffee, you will score better on a subjective outcome measure. We know that if you have that it's done first thing Monday morning and Friday afternoon, you will score differently. So these subjective measures, not only are they're a compliance issue, but the bottom line is that they're subjective. And what one person thinks is something is not what the other person thinks. So let's just look at all this differently for a moment and compare that what we've been doing for the last 100 years of collecting subjective data. We've got to stop thinking about that, and we've got to start transitioning to some more objective data capture. So let's have a look. Now, two smart guys in Silicon Valley back in 2008 came up with this. They released it to the world 2009. It first got sent out here in 2010. Myself and Prashanth went out and bought a truckload of these. And this is the original Fitbit. This is the Fitbit. And this is how it was recommended. So this is in the days before your fancy mobile phone, before your smart whatever. This is actually where it all started. The first commercial grade accelerometer for accurate step capture. And this is what is inside it. Just a simple 3-axis accelerometer, nothing fancy. And myself and Prashanth are really proud of this paper. This is the first attempt for someone to try to look at subjective scores versus objective scores. Funnily enough, the outcomes were actually relatively similar, but not exactly similar. Let's just go through. This is one of the patients that was in that study. Here's a 2-level T-lift with a bunch of perk screws. And this is that patient's recovery over a 12-month time period. I won't say what his ODI was. His ODI really didn't change that much. His VAS score really didn't change that much either. But somehow his activity levels have improved by 30 or 40%. So the objective capture of this guy's interaction with society, which is walking. If you want to interact with society, you got to walk. Don't walk, no, poor interaction. And so we can see that objectively he's actually improved. And now, what type of objective measures beyond step count can we start to incorporate? Well, there's a whole sea of really fascinating sea of data that we can collect. We can look at step count, we can look at step length, we can look at other features, as double step time for looking at elements of how stable we are when we translate through space. So all of these really fascinating metrics we can start to use for objective capture of and here's a great example. Here's a patient from a couple of years ago, big juicy disc. This is the kind of op that we all like, that we all love to do. And we've put one of these devices and we've captured really detailed metrics about this patient. However, on about day 45, he phones the office and says that something's not right. So we look at his data and say, oh, okay, yeah, maybe something isn't right. And we get an MRI scan and he's got a recurrence. So I send him for a nerve block here. And fascinatingly enough, this patient had 1 day of benefit after his nerve block. I'm not sure if that's the peripheral effect of the steroid that's made him feel a bit high, or it's been the nerve block itself, but we can see, boom, his step count's gone up, his activity levels have gone up, but then they've come crashing down, presumably, after the effects of the nerve block have worn off. He then gets admitted to hospital, and here on the blue arrow is where he's had his redo microdiscectomy. And pretty much immediately after the microdiscectomy, on what's that, day 63, his metrics almost returned back to the back to his metrics after his initial microdiscectomy. So we can just read from this how powerful objective data capture is. And you try and compare that, you try and tell me that capturing an ODI at one time point before surgery an ODI at 3 months and an ODI at 12 months, if you try and tell me that that is a comprehensive capture of that patient's recovery, I've got to tell you, well, I don't think it's a comprehensive capture at all. Looking at this graph is a very comprehensive capture. This is a lady that I've been keeping an eye on over the last couple of years. She's in her early 80s and she's got crap stenosis. When I first met her, where's this? October 19. She's got no walking aids. For someone in her early 80s, she's doing 3,000 steps a day. She's walking at about 1.1 meters per second. She's actually, that's actually not too bad. I've talked her out of having surgery. I said, okay, sure, your scan looks like crap, but your activity levels are pretty good. You know, I'm not going to make you that much better. She comes back to see me in March and her step count has dropped dramatically and her walking speed has also started to sort of slip off. So I can tell that this patient's starting to run into trouble. I can't remember why, but she didn't want surgery at that stage, and she started to use a walking stick. But then I saw her again about a month ago, and she's real crap. She's doing a couple of 100 steps a day, which basically means you go from your bedroom to the toilet and the kitchen a couple of times, but that's about it. And she's also needing a walking stick, and her walking speed has dropped to less than 0.5 meters per second, which, trust me on this one, that's a measure where you're really starting to struggle with your capacity to be able to integrate with your surroundings. I haven't operated on her yet. She got COVID. Here's another really interesting case of the power of objective data capture. So this is a chap that I did an ALIF on about 10 years ago. He then got some back pain. One of the pain guys put in a spinal stimulator. I ended up doing a redo microdiscectomy on him here. So we can see in terms of his VAS, and this is an honor score. So he filled out his VAS on an app on a daily basis. So we can see the long-term variance of his VAS over a number of years. However, this is where it starts to get that disparity between subjective and objective. And this is as in your face as what you can get. So after his spinal stimulator implant, his activity levels have actually plummeted. I can't work that out, but anyway, maybe someone rejigged the spinal stimulator here and he started to recover. He started to get a lot of recurrent nerve pain here, redo microdiscectomy, and again, his objective measure of activity levels has started to improve. So really immersive stuff. His sleep patterns. We can see that his REM sleep and his total sleep hasn't really changed after the stimulator. But interestingly, after his microdiscectomy, he was dropping down before the microdisc. And after the microdisc, his sleep patterns have actually improved significantly. So again, yet another objective, powerful measure to capture patient progress after an intervention. I'm big on heart rate variability. The lower the score, the more crap you are, the higher the score, the better. HRV is a measure of how our sympathetic and parasympathetic system is balanced. And again, after his microdiscectomy, his heart rate variability has gone down, presumably stress. And I asked him, and that he was off work. This guy loves to work. He was off work and he returned to work at around about this point here. And fascinatingly, that return to work and his heart rate variability, which is a measure of stress, has started to improve. So again, I mean, there's all this data. There's data dripping off us every second of the day, and it's measurable, and it's important, and it's objective, and it's continuous, and it's good stuff. So I'm hoping that I'm presenting I'm hoping that I'm trying to get you to ask some of your own questions about your own practice here. Here's Jane. She's 25. Here's Jane, she's popped a disc. She's now in her 50s, and we can start to see that her objective measures are starting to change. And she's now in her 80s, and again, we can start to use these measurable data streams to get a real feel for how bad her deficit is and how bad her condition is. We can start to use these devices to measure angles, Euler angles, body position. And we can start to see lateral list or forward stoop with spinal stenosis, and this is measurable. And I'd ask you that in your own practices to start to think about the use of these measures, and you'll find them really, you'll find them after a while to be far more powerful than the VASs that you're capturing or the whatevers that you're capturing. Case in point, here's a patient who over time has changed their what's happened with them, because they've gone from a stenosis, from a disc to a stenosis. So again, what we were talking about before, that it's hard to measure 10 years down the track because there are so many other pathologies going on. This is one way of collecting data, putting a patch onto you, looking at the movement data, gait detection, et cetera, so that we can measure all of these streams. So all I'm really saying is that how we move, how we ambulate through space, our activity, and all the metrics that are in our bodies as we in our day-to-day lives is actually the most accurate measure of our health, not a tick box, not an ODI, none of this. I know that that's a little bit offensive of what I've said today, but I'm talking from one very extreme end of the spectrum, of course, but I do believe that there's a role for a marriage between objectivity and subjectivity. I think that we'll see the last years of data capture, the last 50 years, as what I call the subjective era, and I think that we're now moving into the objective era. So that's I hope that I've helped to just to plant some seed in your own head that the future, that how we look at patients over throughout their treatment journey can be looked at very differently and objectively. Thank you.
Wow, Rick, thank you very much. That is a very important topic, and a lot of thoughts gone into that on from you and Prashanth over the years. And I think the wearables and the fact that everyone's got a phone just makes this accessible now, right? And we can track and monitor things. I suppose one of my questions is, how have you found the compliance with these measures? So like patients remembering to turn on the app, or remembering to put their Fitbit on every day in the earlier days. What have you found is the overall compliance? And do you have your nurses or researchers calling to just remind people to put their Fitbit on in the morning? How's that working at a practical level?
Yeah, I mean, so we started this study back in 2013, and I've got to tell you, patients just look at you real weird, because the concept of a step count wasn't really talked about there. No one used the word, okay, what's your step count? Or so at that stage, it was quite unique. Myself and Prashanth employed a medical student. His name's Monish. He's now our neurosurgery registrar. 8 years later. So so we got poor old Monish to phone every patient every day, get that clip and put it on your belt. And so that was so yes, in the early days there are significant issues of compliance. You can try and make compliance simpler by having one like a single point wearable, whether that's your mobile phone, whether it's but mobile phones and wristwatches, they can capture only so much. But really, is when we're starting to talk about the wearable, the stick-on patches, that's when we take it to the next level in terms of what we're capturing. It needs to be simple and easy and stickable and forgettable. Really, that's the way that these things, the companies who are developing this tech really need to think about that compliance is key. So yeah, good question, Mike.
Yeah. Clive, just a quick follow-up. I know that you've been heavily involved in the setup of the true sham-controlled decompression spine surgery trial in Australia, which I think the results are going to be fascinating. Yep. Are wearables included in the outcome measures for that at this point, or not?
Oh, Mike, that's a very, very sore point with me. So this is a bit of a problem, because if you want to, I mean, if you're biased to show no effect of a study, the best way to show no effect is with a subjective measure. To choose the right subjective measure that you can manipulate the stats. if you want to show benefit and you've got objective measures, it's very difficult to morph the stats, to cheat, to get up to your usual statistical trickery. So I'm not saying that the trial that I'm part of is using those tricks and techniques. However, it was a very sore point that they would not accept objective data capture. And especially as that study is looking at stenosis. And I mean, it's probably one of the best pathologies that we have at looking at objective measures. I mean, how active we are. And it's in a patient population where that's really important. We get into our 60s and our 70s, and our hips and knees start getting crappy, and our mobility starts getting worse, and our interaction with general health and interaction with society starts to diminish. So these are actually really important metrics to keep. So unfortunately, I didn't win that fight. I know that I'll win a lot more, but as far as that particular study goes, it's a work in progress. We're up to about 23 placebo operations. We've got to get to 80, so we've still got a lot more to go. So it's, yeah, watch this space.
Oh, that's a very important work, Rafe. And Prashanth, you had a question about data.
Yeah, Rafe, I just wanted to find out I mean, I know what I would feel if somebody's looking at my data, and I'm sure what do the patients feel that you're going to be looking at their data all the time?
Yeah, I mean, that's another good point. I mean, how to try to de-identify data capture is, you can look at it on one hand, and we've all got a Facebook account, and I'm telling you, Facebook knows everything about you. They know what's going through your head, where you are, what you're doing, how you're doing it, what you're eating, where you're eating it. I mean, everything. So, I mean, we're living in the realm now of where we're accepting that, Big Brother out there knows a bit more about us than what we'd like to, but we're accepting of that, and especially the younger generation, like younger people are even more accepting than sort of than the oldies. So it's I mean, that is a big issue, I suppose. For companies who develop this tech, I think it's important that they think about giving the patient comfort from the very start of that data capture, that it's all de-identified, etc. We're seeing the same thing with vital signs capture. There's a number of pretty funky smart devices that you can stick on your chest, and it's capturing an enormous amount of your vitals capture, your heart, your cardiac output, I mean, blood, whatever. So, and that can be used. That's very powerful. If I was my brother running my insurance company, and Prashanth, if I found out that you, that your heart was looking a little bit dodgy, I mean, I'd be thinking twice about insuring it. I mean, so this is the real problem that we've got. Trying to de-identify, trying to be fair and honest, and where does that data end up? But yeah, I mean, good question. I don't have the answer to that.
All right. Have the panelists got any other questions for our guests?
Yes, Ralph, thank you very much. Alexander from Switzerland. I just want to mention that if you observe a system like this and the patient observes himself, you have big influence on the system. The patient wants to control the system, and this is not invisible measurement. So my patients come with Excel sheets, and they show me how many steps they do a day, and they have their follow-up, and they know that measurement can happen, and they have the feeling that they can interpret some quality out of their data. And This is a problem. I have patients, they get up in the morning and then they walk, do their 5,000 steps within 2 hours, and the rest of the day they are on the sofa and they're eating. They are. I don't know what is this objective data, really good data, or do we do an evolution? And these data we are collecting at the moment with these activity trackers is crap data, but fancy digital crap data. I don't know whether this is the truth. Is this really the meaning? We know from physics, if you observe a system, you're influencing it. I don't know
Yep. No, I totally agree with that. So that's called the Hawthorne. That's called the Hawthorne effect. If you look at someone they'll act differently. If you stick a video camera and a news reporter in front of you with a mic, like with the mic, you're going to act different. I mean, how I'm talking now is different to how I act, like after this Zoom call's over. So the Hawthorne effect is real. However, the challenge is that if we make these devices less intrusive, stickable, so patients kind of forget that they're even wearing them in the first place, then I think that you'll start to see creep in terms of the patient almost forgetting that they've got a device on. And it's not just, I mean, I can see your concern with step count. Step count perhaps is probably one of the like the high value propositions for a patient might see, okay, I can improve my step count and I can make my surgeon happy. However, it's a lot more than step count. Walking speed, step length, stability, single step time, single support time, so that there's all of this other data, not just step count, but there's all this other stuff that really is quite immersive and that is not on the patient's mind. The patient is not thinking about, I want to increase my step length, or I want to increase my walking speed, or so that there is a lot of other data capture that you can do. I would call it a silent data capture. That really is quite important and can tell us so much about that patient's general health. It's not just their walking. It's the whole thing. It's the sleeping metrics. It's the sitting metrics. It's the walking. It's everything rolled into one. So I agree. Your concern.
I agree completely.
Yeah.
And for example, what you mentioned with the sleep time, it's fantastic how surgery improves sleeping in scores or in these objective measurements. And if you look for smokers before surgery, smoking a lot in pain, and after, these objective data is so good, and I love these activity trackers. I believe in them, but I don't know whether it's really good at the moment.
Oh, gee, just you wait. I mean, I'm convinced. For one of my sort of final quotes when I retire from this gig, I'd like to sort of have this, that we've gone from the subjective to the objective era. I think that I'm hoping that that'll stick. Yeah.
Thanks, Rafe.
Just before I go, a huge thanks to Virtual Spine for putting on such an awesome gig. A great thanks to Prashanth. We've collaborated on all sorts of crazy stuff over the last 10 years, and so it's and thanks for having me.
Oh, absolute pleasure, and Prashanth, and I just want to thank you guys for the effort you put in for all your research and work, and just being able to present it so well. And it's good to have people passionate about outcome scores. I have to say that it's something that I wouldn't say I'm passionate about, but I recognize we very much need to do. And I'm happy to take your lead on what the best thing is at the time. We've raised a whole bunch of points here today that are probably whole virtual spine meetings in themselves. One is what to do with the facet joint cyst, and that's I think quite controversial. The second, SIJ fusions. Third, spinal cord stimulators. We've been talking about in the chat box as well. So we've got a few topics to move forward with for Ali and the team. I think we are coming towards the end of the hour. So if there are no more points or questions, I'd like to thank our two guests today, Rafe and Prashanth, and our panelists, and Ali, the whole team, and Aaron, who's been running things in the background as the medical student. And we just heard from Rafe about how the medical student that he made do a lot of hard work is now on the neurosurgery training program, and will be fully qualified and joining you guys. So yeah, thank you, everyone. If there is no further questions, we will.
Mike, hey, this is John.
You're going next week. Sorry, Ali. Next week. Yeah.
No, I was going to say thank you so much. That was an awesome session. One thing I wanted to say very, very quickly before time is over is Ralph, I agree with you 100% that and about in terms of how results can be changed or not. I don't want to use that word, maybe not change, but the study investigators can get a desired result based on how that study is designed. And study design is one of the most important things. So for our trainees, you should always read these studies with an objective eye, and don't believe everything that you read, because it's just, a lot of these studies are not, they're designed to get a certain outcome. It's very, very important that you just stay objective and you really read these studies critically. So this was a great session. Thank you very much. The last thing I want to say.
Jay, are you hosting next week?
Yes, I am hosting next week. We're gonna have Peter Feister. He's a neuroradiologist at the University of Florida. He's gonna be talking about craniovertebral junction pathology and trauma, and he should be giving us some really interesting cases. So I'm looking forward to that. Looking forward to seeing everybody there, and have a great weekend and rest of your week.
Thanks, Jay. I second that. We'll see everyone next time.